Good afternoon, everyone. And for those of you joining us from elsewhere in the world, perhaps it's good morning or good evening. Welcome to this session. If you were asked 6 months ago whether we'd be in the kind of world we're in, I'm sure you probably would not have predicted it. COVID-19 has brought disruptions to everything we do, the way we learn, the way we work, the way we play, the way we care. And there's some very interesting developments, like our opportunity to actually connect with each other through sessions such as this one, and learn many things about different parts of the world. And that gives us cause to pause, reflect, think about what we do now and what we do for the future. So around the world, we are hearing conversation that COVID is a catalyst for change. Change in the way we work, change in the way the health services are provided, change in the economy. But what does that reset look like? How do we actually get there? How do we manage these current uncertainties and challenges? How have we navigated over the last few months? And where do we go for the future? These are the critical leadership challenges and leadership questions. And we need to think about what are our leadership skills sufficient? And are we sufficiently well prepared for the future? So over the next hour, we want to explore these questions with our amazing panel. I am really excited. We are very, very privileged to have with us Dr. Takeshi Kasai, Regional Director for the World Health Organization in the Western Pacific region. I will say a bit more about him in a little while. We will also have, at the other end of the age spectrum, me being the oldest, of course, Max Lim, who is a medical student, and Max is the youngest and just going through. So we're looking forward to a future leader here. And we have Nicole Lam, who amazingly enough managed to get her nursing degree and her master's degree all in one go 3 years ago. And she's working on the front line. So thank you, Nicole, for being with us. And we also have Julianna Yeung, who graduated from the MPH last year, having started out in life as a biomedical engineer. So she's had a lot more experience under her belt. So I'll do a bit more introduction as we go. We have collected questions in advance. I have asked our panelists to build their responses into the questions. So let's see how we go, and I hope we can cover everything in the time that we have. So without further ado, let me go to Dr. Kasai first. Dr. Kasai, you started out working as a public health doctor. You've been the head of a prefecture health department. In Japan, you've done your also postgraduate training overseas. You've been in the WHO for quite a number of years, leading in a number of technical areas. You were the mastermind of the Asia Pacific strategy for emerging diseases, and now as the regional director for a year and a half, elected unanimously or nearly unanimously by the member states. And last year, you issued a white paper putting on the table the importance of thinking about the future, being prepared for the future, and understanding how we go from here to there. But there is here now. The future is with us, perhaps a little bit sooner than you had anticipated. So can you tell us about this uncertainty? I mean, any emerging infectious disease will pose a lot of unknowns. And if we're lucky, we deal with them and we're finished. This one has been going on for a long time, and the end is not very clearly in sight, I think. So what uncertainties have you had to address in this time?
Thanks, Vivian, for inviting me to this seminar together with such a energetic and then admirable panelists. Now, you asked the question about the uncertainty and decision making. There's no such a decisions without uncertainty. I'm sure the listener connected to this seminar had the moment in the past that you had to make a difficult decision with uncertainty in the past. Outbreak response is actually a series of decision making. And the more earlier you detect, the less information and the more uncertainty. And actually some of those decisions is with a very heavy consequences. And so to make this difficult decision, we use the method called risk assessment and risk management. I remember that 31st of December 2019, after actually I had my last meal of the 2019, I received the information from my deputy about the information of cluster of unknown pneumonia related to seafood market in Wuhan and China. He also mentioned that there's a team from central levels are now going into Wuhan. Actually, after 2003, when we experienced SARS, we have established a system to monitor the event in this region that might pose a threat to international community. There are keywords mining the internet and pick up the relevant informations in these regions. And actually, that system detects once in 2 to 3 days those potential events that might pose a threat to international community. And on that day, all three levels, the WHO headquarters, regional office, and country office, all detected this information and start to activate their risk assessment. And following day, our country office validated that there is a official information on a local government website. There were so many uncertainty at the beginning. And of course, one of the possibility is another SARS or something like a MERS or other diseases. And we bring our past experiences and knowledge into those risk assessments. In the case of unknown diseases, I received these questions. People might think the first risk questions you put was about what is causing these diseases. Yes, but actually, no. The first questions we ask is that whether the local government of the epicenter has a sufficient capacity to bring up the information or have a capacity to manage those outbreak. If not, we have to send a team immediately to the site. The risk assessment of the outbreak response starts from the decision that we make. The information we got was almost like a model response, and we also got the information that the central government, the National Health Commissions, is sending the team to the front line. Then we move to the next question. The questions about the severity, transmissibility, and the impact. There are informations that we focus in assessing those elements. For example, severity, we check the number of cases, death. For example, the transmissibility, we check if there's any similar case around the nearby hospital, or if there's any cases coming from the healthcare worker, or we also check if there's a secondary cases among those close contact. And as we get information, we repeat the risk assessment. And once we make a decision, we set up the new risk questions and continue our risk assessment to address those uncertainty. The WHO functions in the infectious diseases is defined in the international health regulations. And actually, this 2003 SARS made entire world revise these international health regulations. And so current IHL is the one that incorporating the lessons we identified through SARS 2003. The member states are mandated to share the informations, and then the WHO is mandated to facilitate that. So immediately once we had those information, we repurposed of our China country office staff and then set up the structure and further strengthen the country office by adding the staff to be able to respond and fulfill those function in facilitating informations. The country office have started the regular conversation with the national health commissions in China, using the trusted relationship before this COVID-19 occurred. And China has been sharing the information. And informations such as a gene sequence made all other member states quickly develop their laboratory system. And based on the information, we also inform or encourage all the member states to prepare for the importations of the virus. The emergency committee were called under the International Health Regulation. This emergency committee is the mechanism that after the SARS that IHL introduced to make more objective and transparent decision-making under the uncertainty. So the experts around the world of the subject matter are called under the IHL and assess the situations based on the information submitted by the country experiencing the event. And as you all recall, the emergency committee was called on 22nd and 23rd of January. And actually their assessment were divided. Then after on 30th of January, they concluded and recommended our Director General, the situation is meet the conditions of the public health emergency of international concern. Decision under uncertainty is not easy, particularly the one who has a heavy consequence. So immediately after the public health emergency of international concern declared, we encourage all the member states to prioritize and expedite the pandemic preparedness. Preparation should be a no regret, but actual action decision should be cautiously made. The risk assessment and decisions are continuing even today.
Thank you so much for an explication of what is obviously a very complicated process and giving us a very clear sense of the early days and how the information is dealt with. I think the mining of the internet is sometimes called rumor surveillance. And I think that explanation probably stimulates everyone to want to become an epidemiologist, sometimes known as a disease detective. But having been through that, and now there have of course been many other issues, what have you learned from dealing with these challenges? You know, how did your earlier work on building system capacity help? How do you actually, work with the different countries?
Thank you very much, Vivian. You mentioned about the Asia-Pacific strategy for emerging diseases. Yes, after the SARS, when the international health regulations revised, we also developed the strategy to help member states develop their core capacity to respond to infectious diseases. Actually, we've been very serious. And then the reason why I can share is that we also lost our colleague during the SARS. And we made this as like our commitment, not just only for our colleague, but for those who lost their lives during the SARS. And we've been investing under this upset for the past 15 years. And I'm very happy to report, I'm observing some of the capacity the member states develop using this upset is working in this COVID-19 response. For example, from 2006 to 2007, we have conducted the training in these regions called Rapid Response Team. And now they're functioning as a contact tracer. We also set up the system called Field Epidemiology Training. And then the graduate is really leading the COVID-19 response. And we also established a laboratory system for influenza, preparing for influenza pandemic, or the laboratory system for tuberculosis is now using as a reference laboratory system for the COVID-19. So obviously, the more we invest and develop the capacity during the peacetime, we are much more effective in responding to the emergency. But in the same time, we are really continuously facing the challenge. For example, communication. You asked me the first question about the decision under the uncertainty. It's so difficult to communicate those decisions we made under the uncertainty. And if I recall, during the SARS period, people collected the information, gathered the information through newspaper, through TV media. But now people are gathering information with the very different means. So they really, the way that the people collect information are now changed. I also noted that actually the outbreak response really required a multi-sectoral response. We've been observing this virus can going into the area such as this outbreak response required the other sectors to also be involved in the response, because this virus can go into, for example, like a area where they have a less hygienic conditions, and then the response will become not just a health sector response, but requires other sectors. If we're going to deal with the foreign workers, it's not just a health sector response, but we have to work with the other sectors to respond. If we're talking about the long-term care, still some of them are within the health sector, but we have to work together. And then if that sector, that the facility is like a jail, obviously we also need that other sector to work together. And then lastly, we noted the fact that this virus, we have to live with it. We have to live with it means we have to find a way to, on one hand, continue to implement the control measure, but we have to also bring the society economy back. Or more precisely, we should really strengthen our response so that economy and then the society can back. This again requires not just the health sector, but economic sector, and then the community needs to be at the same table. So to make a truly a multi-sector approach, including the community, is something that we need to continue to strengthen.
So if I'm hearing you correctly about what it requires in the system, there are also perhaps some personal skills required in terms of the leadership. In leading that, the foresight, the proactive communication, the partnership building skills, and being able to lead and bring people with you. Would you say these are some of the key personal attributes that as a leader you would need to have?
Vivian, I know you for quite some times, and then you're really capturing a very important element. But if I may add one more, observing the past 6 months, how the leaders in the government demonstrate their really leadership, I noted that a good leader really listen to the suggestions or the outcome of the technical team. They really listen to the community and make a decision. I found that in addition to the points you listed up, this is a very important also the element I noted in the past outbreak response.
Right. Thank you very much for these opening comments. Let me turn to the panelists and get them to reflect a little bit about the impact and the some of the leadership issues. Let me start with Julianna. You work for a global company. Fresenius is a very large multinational pharmaceutical company. You explained it's been in place for about 100 years. You are the Associate Director for Health Economics and Outcomes, Reimbursement, and Value Strategy. That's a lot of very important things for Fresenius Medical Care Asia Pacific. So you're covering also, you're in a global corporation, you're covering a big part of the region, overlapping with the regional director. What's been the impact on a private sector organization that provides healthcare? And what did you have to do to manage the impacts? And what are the lessons you draw?
Okay. I think one thing I wanted to add to what my company has is we have a network of dialysis clinics as well across the world. And within Asia Pacific, it's across 18 countries. So what I realized was that when Dr. Kasai was describing how WHO first responded to the virus was actually very similar to how we responded as well. Because we have local offices across Asia Pacific, we needed to understand whether our clinics were able to respond to this virus. Because dialysis patients are usually immunocompromised, meaning they're more likely to contract the virus. So the first thing that, from what I understand, the company really cared about was whether our staff, our frontline staff, had the protective gear to protect themselves from the virus. Because within a dialysis clinic, there is constant interaction between the patients and the clinical staff. So in a way, we're protecting our clinical staff in order to protect our patients. And then so when the virus first started across Asia, regardless of how much we prepared in peaceful time for these type of emergencies, it's never enough. So we very quickly realized that there are not sufficient PPEs for our clinical staff. So what happened was that we reached out to our counterparts in Europe and in the US to see if we can actually get their spares to ship across to Asia Pacific to tailor for this epidemic. And then this is where I really echo the collaboration across functions and countries, because I witnessed it within my company. Everyone across, like from procurement all the way to our clinical teams, they work together to really ship those protective gears from across the ocean to Asia at the very beginning of the virus. But then, as you guys all know, that the virus then spread to our counterparts in Europe and in the US. So what happened was that initially they were the ones shipping the protective gears to us. And then around April, where the pandemic was the highest in those countries, China started up production again. So it was the reverse. Now we're gathering the protective gears around Asia Pacific and then shipping it back to our counterparts in Europe and in the US. And then very similar to WHO, very earlier on within the company, they established an emergency response team, which was gathering all the clinical experts amongst the company. And I think that was very important, very similar to what Dr. Kasai said, was that this, I felt like the management team of my company really listened to this group of experts in terms of how we should respond to the virus. And I think I can really say truthfully that at the beginning, even our colleagues in Europe and the US, they didn't felt like it would go to them until the point the virus did hit them. So I think what I understand from my colleagues was that they then really learned from Asia how we dealt with the virus in our clinics and then take similar measures in their clinics in order to manage the pandemic. And then actually the response team looked a lot into WHO for guidance. We set up a website, internal website, which is called like a global emergency response hub, and WHO is right there in the middle. Like whenever WHO release new guidance, we also update it on our site. So I can really echo basically almost everything that Dr. Kasai said. Like, of course, for a global company, we're in a much smaller scale. But I can really witness firsthand that collaboration across functions, across countries, is really what it takes to manage a pandemic of this size. You know.
Thank you very much. That's really interesting, the parallel you were drawing with the WHO. But I also thought, as part of that collaboration was the reciprocity that, you went to Europe and then they had to come back to you. And you were also having to listen to experts, the way Dr. Kasai reflected on the approach in many different countries. So fascinating parallels, despite the fact that one is working with really governments in the public sector and you're in the private sector. I want to now go to the front line, because at the end of the day, it doesn't matter, what we do up there at the global level. It's always about the patients, the families, and what happens. And Nicole, you work on the front line, providing patient care in a hospital setting. But you don't work in infectious disease, so you're not seeing COVID patients. In many countries, we've heard about services being shut down because countries only want to provide COVID. But I think you had to keep providing services to your patients. So what's been the impact of COVID on your patients, and what skills did you have to call on to support them, to work with them? Did you have to do anything that was different?
Thank you, Professor Lin. I'm not one of those working in the isolation zone yet, but then COVID clearly does affect every part of our healthcare system, because we are new to COVID and it comes very fast, especially in the first phase. So it leaves us very little time to prepare. So what we have been doing is really workload redistribution. We try to suspend some non-essential or non-emergent services, like some simple general outpatient clinic follow-up or some endoscopy examination with no urgent indication, so that we try to retain the manpower and the resources to relieve us, our colleagues in the front line. But then the challenges come is that we are uncertain when the COVID is going to end, while the demand of those suspended services will not easily go away. So this is a time that telemedicine is a new approach to optimize our existing service provision. For me personally, I did encounter patients who try to default their follow-up for various reasons, like they do not have enough masks at the very first phase, or they want to stay home to remain social distancing. As for us, our medical staff, of course, we would like to preserve our PPE, and we also want to reduce a surge of patients to a certain point at a certain time. So telemedicine really comes as a new approach, which is accessible and convenient, that it helps to provide the necessary care while reducing the transmission risk of COVID. Prior to COVID, it is really not something very common in Hong Kong right now. But then, as there is more restriction now, I know that some places, they are trying to run a pilot program. For example, for those who need minimal internal inspection, like assessing a very simple post-operative wound, or for those patients who are chronically ill, like with diabetes or with hypertension, basically they attend a face-to-face follow-up is just for topping up their existing prescription. So for this type of patients, the modality of using telemedicine actually increased ever since we have COVID. And there's also another form of telemedicine happening right now in Hong Kong, which is in the Lee Yu Moon quarantine site. This is a quarantine site like a step-down ward, where patients of relatively more stable conditions, we basically give them their own set of thermometer or blood pressure cuff. They measure their vitals every day, and then they input the data to the tablet. And the information actually just goes to the nurses in the remote center to receive. This is a kind of store and forward technology, kind of new, and we need to take some time to review its effects. But then incorporating this concept to our step-down quarantine site does help us to triage more space in the tertiary hospital setting so that we can cater the surge of more critical patients. I do hope that this kind of telemedicine modality can continue to sustain even after the COVID. But then we need to think of like incentives like money reimbursement, or we need to think of ways to protect the legal responsibility, the confidentiality between doctors and the patients. And it is also important to make sure that the community is actually ready for this modality, say our laboratories, our pharmacies, and also our community services. I'm also hoping that there will be more development of portable devices like portable stethoscope and portable ECGs. So I'm hoping the future trend will be expanding the digital health while continuing our existing conventional healthcare.
So perhaps telemedicine is a silver lining in our current global crisis, that we will actually be able to move towards a more accessible and low-cost way of providing services. But I suspect part of the challenge, besides the patients, is also the way we have to train our doctors and nurses and other health providers to actually be able to use the new technologies well. And I'm not sure that old professors themselves know how to train, but perhaps that's something we need to think about. So let's go to our youngest person, Max. So at Hong Kong U, of course, we know that in your third year of medicine, you get out of the classroom, you get to go away, you went to Manila, and you saw WHO from the inside. And then you went off to France and studied international public policy. What an extraordinary experience. You came back for your clinical, but then you got disrupted with COVID. But in the meantime, you've had this exposure to a global way of working and thinking, and then you have had your training disrupted. So does this combination of experience make you think any differently about learning about medicine or practicing medicine, or different kinds of skills you think you need to be developing further?
Well, thank you, Professor Lin. I think the main issue with COVID and the medical training process is that medicine, it's something that requires consistent effort, because you need to develop that clinical sense, and you can only get that clinical sense over extended periods of exposure. And as much as we'd love to see these advances in telemedicine, there's nothing that really replaces real patient contact, which is so vital to the medical training experience, at least for frontline medical professionals. And that's the aspect that we are missing during this period of COVID, because as much as we can deliver non-clinical aspects of teaching, we cannot replace that clinical bedside teaching. And thus the disruption to our clinical medical curriculum is very large. I think the one thing to note is that, at least for HKU, the curriculum by itself is already so packed within the last 3 years, the clinical years. There's not really much leeway in order to frame shift it or to delay it further, in order to not compromise on the quantity as well as the breadth and depth of our exposure. And thus this knock-on effect is already going to have a knock-on effect for cohorts 5, 6, 7 years down the line. We won't be back to normal until perhaps something closer to a decade, simply because there's not much of a gap, and thus there's not much of a buffer zone, so that the subsequent years, they're going to be affected by our delays in training too. So that's one aspect to consider. It's the fact that we're finding a tough time balancing between having the proper clinical exposure so that we graduate as competent doctors or medical professionals, and the reality of COVID. It's that any type of personal close contact without, say, any advancements in vaccines or treatment, it's basically still very, it's not ideal in this situation. And as for me personally, like looking at these situations, obviously there's always the benefit of hindsight, and we can always go through a post-mortem analysis and say, well, these governments should have done this, that at this time, you know, WHO should have done this or that, or the medical faculty should have done this immediately. But it just really, as Dr. Kasai has said, it really takes away from the fact that at the beginning, a lot of information is unknown. A lot of things are unknown. And it's very hard to react appropriately to a situation given the unknowns at that time, because there's one path can diverge into multiple different scenarios. And at that point in time, you have to make a decision based on many unknown variables. And I think that's the aspect we forget once we do a post-mortem analysis and say, oh, why didn't you do that at that point in time? So I think instead the focus would be on not the specific responses to whatever happened, but rather the skill set and the knowledge or the skills that we developed in order to make a correct response depending on the context. Being adaptable, being flexible, being tenacious, these are skills, and the perspective mindset of collaborating with different sectors, being open in terms of knowledge transfer and whatnot. These are important skills, important cornerstones, important qualities that we should focus so that we are more resilient in the case that another public health issue, which is as disruptive as COVID, happens in the future, because we know that these things will happen again. And thus it is the system level as well as the personal level capacities to adapt and to be flexible and to be resilient that I think are the most important and should be the most important quality in training future healthcare professionals or even any subjects relating to health looking forward.
Okay, so Dr. Kasai, if Max talks about some of these personal qualities being important, like being adaptive, being flexible, being able to take knowledge, put it into context, resilient, did you see any examples of this sort of behavior among some of the national leaders you've been advising during the last few months? Are you seeing these sorts of personal qualities and skills actually leading national responses to COVID?
Very much, Vivian. And I just wanted to also congratulate Max. I'm very impressed by his intervention. I hope that you gained those kind of capacity while you were a WHO intern. Let me answer to your questions rather than I give the observations of the leaders. My observations of the WHO staff who deliver the good output had a very common characteristics. And I wanted to share that and then they make as answer to your questions. Number one, obviously, they have a very strong technical competency in their expert area. And I found that it comes from their curiosity. They really ask the right questions in the right timing. Then secondly, we're working in the public sector. So obviously, technical knowledge is not enough. We have to have the skill to bring that up to the policy level. And I found that the staff who had that capacity had a very high cognitive skills. They know which button to push in which timing. But not only that, I also noted that they have, this is my terminology, but professional sincerity. They have a capacity to judge what is really, really correct things to do. And obviously, they also have a very charming personality, individual personality. I think I should not say charming, but I found that those people have a very high empathy. And then they're really trying to understand the people who they wanted to serve. So those are the common characteristics I found with the staff who really have the high performance.
That's really interesting because these are obviously skills that you develop early on and then you have to keep cultivating while you're working and the more exposure you have. But I'm also curious, through this pandemic, we've really had a lot of rumors, false information, conspiracy theories, what has come to be termed infodemics. I wonder if any of the four of you might want to comment on this problem of, we've talked about communication being very important. And of course, working in the health area, we're very strongly focused on the evidence. So how do we work with people who are searching for all kinds of information when there's a whole lot of different rumor mills going around? What does it take for us to actually, get everyone to actually focus back on what the evidence is and counter the infodemic? Any of you want to comment on that?
I think as a frontline healthcare worker, communication is really an integral part to ensure our smooth day-to-day operation. And this is even more important in times of COVID because the situation changes from time to time, and we really look for guidelines to guide what we do. So what we are looking for from our leaders are really transparent, clear, and timely message. Otherwise, when we have no idea what we have to do, we will be in panic because what we do is really risking a matter of life and death. And also, these kind of messages should not just be spread by word of mouth. There should be clear printout that is easily accessible for everyone. And also, it is important to have a platform or a channel for us to allow feedback, because that's how our difficulties in executing a certain policy is addressed. And that's how we bring continuous improvement in frontline.
So really getting that connection at all levels in the system is very, very important. Anyone else have a comment on this?
Well, I like to, as the youngest member of this group, I think it's pertinent that I mentioned a bit about social media. Can you see me? Okay. I think it's important to mention a bit about social media, and especially this young generation, especially this young tech-savvy generation that we see shift this media out, or the receiving of media or information from more traditional outlets that are more controllable, more expected, such as TVs and newspapers, towards social media, which is inherently social, which means that it only reflects the opinions of those around you. And I think I have 2 points to make on this aspect, and I know that these might be divergent from what other people think, but I think that's true to me nonetheless. The first aspect is that just because you've got a significant population watching or using social media frequently does not mean that they do not put certain amounts of importance to traditional media outlets. And in that sense, I think that traditional media outlets, they still need that aspect of transparency and consistency in being able to deliver information consistently and transparently in a timely manner. And I think that as a cornerstone is going to be important regardless of whatever technological changes we'll see or changes in the way we communicate, regardless of even social media. But beyond that, I think there needs to be institutions, large bureaucratic institutions need to adapt and change and target directly to this younger demographic or these demographics that are changing in the way they approach information. Social media, as much as it's a new thing, it's been around for a decade or more. We know it's here to stay, and thus we need to treat it as a proper avenue of communication. And I think that WHO, in fact, has done very well, in fact. I was reading this article, I think back in April, of which WHO created a TikTok account. As you know, TikTok is the new social media app of choice, and it actually went viral pretty much immediately. And I was reading the behind the scenes, and in fact, it was only being manned by, I think, 2 employees who were not that senior. In fact, I think they were in their late 20s. So I think having that adaptability and that kind of generational communication and being willing to explore these new avenues of communication. I think being adaptable, being flexible, and not sticking within confined ways of dealing with things which are tried and tested, however, lose effectiveness over time, obviously as times change. I think that aspect of reforming is very important with large traditional hierarchical bureaucratic organizations in order to target this new generational shift.
Yes. So we need to be very adaptable and very agile with the communication. Now, let me go to an issue that's in the traditional as well as social media a lot, because a lot of people really have their hopes pinned on it. And there's so many different ways people are talking about it, which is the COVID vaccine. Mm-hmm. Now, some people say, oh, we're going to have something, by the end of the year. Other people say, well, it's at least 2 years away. There are some countries that are apparently making advanced purchases, and other countries that seem to be putting money into a potential product without a product having already been tested. Dr. Kasai, what do you do with a situation like this? And how do you think we could be, allocating these resources? Because there will be this international competition and there will be very different needs across the world.
Very much, Vivian, but you have so many elements put into one question. As Julianna mentions in her company's experience about the distribution or redistribution of the PPE, actually, this vaccine is a very important issue. In fact, last week, I had several calls with the ministers in the Pacific. Everybody really emphasized the importance of having a share of these vaccines to protect the vulnerable, particularly the Pacific Island countries. I'm not quite sure how many of you are aware, but in 1918, when we had the Spanish flu, they are really the last one to have the virus enter to their region, but they have the most significant impact. That's the background that they're really keen to get the vaccines to be also distributed to their populations. We see this vaccine as a global goods, and I understand that many countries also see that way. The fundamental solution to address this issue is to produce the vaccine as the vaccine safe and effective vaccines in affordable price as early as possible with the volume that we can supply to those who need. And to make that happen, we introduced initiatives called Access to COVID-19 2 Accelerator, which is a pledge for many member states to expedite the development of the vaccines. But not only that, they pledge for the equal distributions. And then the big challenge for us is to how to really materialize this pledge into the reality. When it comes to vaccine, myself is on one hand very optimistic, but on the other hand, I'm very cautious. I understand that there is a very convenient English called cautiously optimistic, optimistically cautious. I forgot the order, but basically, I'm observing unimaginable speed of the development of the vaccine. I have never seen. I've been working for the infectious diseases for so long, but I've never seen that there are more than 114 candidate vaccines coming in such a short period. Out of that, 25 is already moving into the human trial. And then some of them are already in the last stage. So obviously, it's moving in a very fast speed. And I'm sure there will be a safe and effective vaccines might come in with much, much faster speed than we experienced in the past. But I'm also cautious because vaccine need to be really safe. Expediting speed cannot compromise the safety. And vaccine, we're going to have a huge number of people going to get. So we have to really make sure the safety. And also another biggest challenge is about the mass production. From those candidate vaccines to the mass production is another technical big challenge. But again, a little bit more optimistic side, there are multiple companies with different methods moving forward. So I really look for those vaccines to become available with the safe and effective, but also affordable price. But I think we have to face with the reality. It's not that we can make from the beginning enough quantity to satisfy everybody who's looking for this vaccine. So we need to come up with some kind of agreement, solidarity, to make sure those vaccines are distributed in the fair manner. We need the understanding and agreement who is vulnerable and who is living in the vulnerable context so that they can receive this vaccine. And come back to my original point, the Pacific people, they're in the UN statistics, it's classified as a middle income country. But if you think about the population size, if you think about the environment they're really living in a very difficult natural environment. And if you use the population size and then compare with the other country, their share is almost becomes nothing. And so this is again important moment for all of us to think about the other people and then to have some empathy and then come up with the agreement in making this distributions as fair. I know it's not an easy challenge, but I think it's a test for everybody around the world to find some solutions to that.
Very, very challenging. And I think perhaps this goes to everyone wanting to pick up Julianna's profession, which is, thinking about resource allocation and priority setting, cost effectiveness. Add to that fairness, ethics, solidarity, and empathy. And the question might be, are we doing enough in this area in all our health professions training courses? And perhaps that's something I ask everybody to reflect on as we move towards the end, because I think our time is now getting close. So, and so I do want to think, when we think about COVID and the reset, we're really thinking about what should the world look like for the next generation and what kind of leadership we need for the future. Maybe if we were better leaders, we wouldn't have a world as it currently is. So again, I go to you, Dr. Kasai. What do you think you could have been better prepared with? Could the university have taught you better? Reflecting on your many years and many challenges.
That's a very difficult question for me to answer, but I'm quite comfortable to observe so many of our WHO staff had the capacity, competency that I have mentioned, and they are really continue to try to gain those competency. And then I hear that some of them actually refer to the educations in the university, in the academia, that they gain the capacity to deepen their technical expertise. And some of them refer to their capacity in working in the government or working, even we have the staff working in the private sector in gaining, we just refer about how to allocate the limited resources or how to develop the policy. And then many people also refer to the experience of international organizations, understanding a different culture and knowledges in developing their sense of empathy. So it's a very difficult question, but let me answer in this way. I think there are multiple ways to strengthen those capacity. And I can see that the academia plays a very important role in stimulating the student in gaining those competency.
And would you have people beyond Max to come to WHO and gain some of these competencies?
I have to have an offline conversation with Max that if we really offer a very good internship, but we call for intern twice a year. And we're really trying to really offer the opportunity to the intern to expose those competency. So I'm very much looking for if there's anybody who is interested in applying for that internship. In fact, at the WHO, I don't think we have a student or the nationality from Hong Kong, China. So I'm very much looking for if there's anybody who is really looking for that kind of career path.
Great. Now, Julianna and Nicole, again, reflecting on your recent university experiences, do you think you've been well prepared for the current uncertainties and challenges? And what would you like to see more of if you were to come back and do it all over again?
Nicole, would you like to start first?
Okay. For me, I'm grateful that my nursing training here really not only give me the skills, but also the attitude that I need to face challenges. And then in MPH, it is really of an eye-opening experience, because I'm sure for most of our medical training, we are trained to think in a very sophisticated way. We tend to pick up small details and then we form a clinical picture. But then in MPH, it really drags me to think out of the box and to think from a wider perspective. Like in this COVID, it comes as a challenge with a lot of uncertainties. But then we shall also take this as an opportunity to learn from our mistakes and to think of how we improve our future development. And if there is one more thing that I would like to see, maybe I should put it in this way. I wish I joined Hong Kong U a few years later than I did, because as far as I know, every student here now, they can enjoy an enrichment year. I'm not sure about this, so Professor Lim, please correct me if I was wrong. And that's really gonna be a fascinating experience, because for most medical or nursing students, probably 95% of them will join the frontline healthcare, and that's how they're gonna spend the rest of their career pathway. But then having an enrichment year, for example, you can engage in things like doing an exchange, engage in humanitarian work or research activities. So this is probably the only chance that you can be so carefree from the burden of work, the burden of life, to take a look in this world. So to all our DSE students out there, do come to Hong Kong U, try something new and get inspired.
Okay. Julianna?
Yeah, I let Nicole go first, even though experience-wise, I'm older, but she's actually my senior regarding MPH, since she did it earlier. I guess one thing I would like to add, and it goes to similar to the social media question, is I see a lot of untrust in the system and or lack of trust in the system and institution. And I think we need to start thinking about how do we build trust back into the system. I think, let's just say Max, Nicole, and myself eventually will be in leadership position in the future. I think that is probably something all of us should think about is, have we let certain people down such that there is a lack of trust in a lot of people? And that's why a lot of these so-called information bias happens, is people only want to believe what they want to believe. And that's something I think we should explore, because even when I was doing the MPH, I do see some of my classmates even not trusting the system already, even when they're in the program. And I wonder, to a certain extent, have we kind of let the younger generation down? And that's what it is, because I guess I came into the MPH program as one of the older students and I do see some gaps in terms of how I was taught in my undergrad versus some of these students. I see a bit of lack of trust in the system, and I think that will be something I think we should work towards. And I am with you, Dr. Kasai. We should be cautiously optimistic or optimistically cautious in terms of how we lead the future in this post-pandemic world.
Really important thought, warranting a lot more discussion. Last but not least, Max, you've still got a few more years to go. And, thinking about your cohort and generation, how do you think we could foster greater, understanding of this solidarity and global health?
It's a tough question because I think safely we can divide the world into the history of the world into pre-COVID and post-COVID. When we emerge from COVID, it's going to be a dramatically different society. We've already seen so much changes in politics, in society, in the way people think and the values and whatever. Everything's changed, and I think that's one of the challenges. Really, we don't know what we're going to be dealing with. Not even we're post-COVID. We don't even know what we're dealing with in the next month. And I think that I'm very hesitant to make any kind of predictions about or to make any kind of judgments. But I think what I will focus on, and I've said it again, is I think that there needs to be a quality or a mindset towards acknowledging different perspectives across cultures. I've seen that, especially with this in the past few years, there's always been this kind of a more nationalistic current where people are looking inwards instead of looking outwards towards neighbors. I really do, and I might be old school in being a hardcore believer of globalization, but I still think it's true in some aspect that there needs to be some intercultural understanding across borders. There's acknowledgement that there are different perspectives and that there's no better or right or wrong answer. There's only different approaches that are relative to the context in which they're based in. For example, as I mentioned, in Hong Kong, I think most of the healthcare professionals go straight into clinical practice after they graduate and stay within the system. However, that's completely different in other countries. For example, in the UK and US, where you see much more very diverse professions after people graduate from an MD or MBBS or in other medical professions. And that's just one example of the different perspectives, different cultural changes between different countries that really impact on the policies that are derived as of that and the perspectives that are derived from that. So I think having this understanding of the fact that there can be different realities, but within the same universe, I think that aspect of global health and global health leadership, in order to bring some cohesion to all of this different approaches, I think that's the most important key.
Great, I love that expression, the differences within the same universe. I think that all these comments really get us to the importance of exposure, of empathy as part of developing trust, and lifelong learning is part of what we do and how we grow. And we learn from everything, successes and failures. And so can I thank you all very, very much for this incredible hour of experiences. And for those of you who are keen to start again, we do have a Bachelor of Arts and Science in Global Health and Development. It's never too late. And of course, our enrichment year for the medical students is now extending into other professions, albeit not quite at the same length. And our MPH program has a fantastic international mix as well. So this is all part of our learning to become better leaders all the time. Thank you all very much for joining us, and thank you again to our panelists.
Thank you very much for this opportunity.
Bye-bye.